Hi, my name is Siobhan Aldridge, and I am a nursing student at Heartland Rehabilitation Center through the University of Michigan School of Nursing. I'm going to present to you a patient currently at Heartland. The patient is MF, a 63-year-old married Caucasian female. She was a social worker, but now the patient is retired. The patient had been in the University of Michigan Hospital since January 2013. She was there for extreme shortness of breath. She was admitted to Heartland in March for the primary reason of rehabilitation and has been there for almost 2 weeks but isn't sure of the exact date she got there. Patient has been receiving physical therapy and occupational therapy. The goal of her rehabilitation is to get the patient back on her feet and exercising. She has developed restrictions and decreased ability to walk due to limited mobility in the hospital previously. The patient states she is in no pain. The patient is also still recovering from a respiratory infection that had developed when she first got to Heartland. The present medical history of the patient. While in the hospital in January, the patient was very ill. She was put on a heart monitor for 6 weeks during that time in January and February. The patient was also having difficulty breathing while hospitalized and put on a defibrillator to help her shortness of breath, which monitored fluid input and output in her heart and blood. Nothing was found in the defibrillator, and it was actually not needed. The patient is no longer on the defibrillator. Upon entering Heartland, the patient was put on a heart monitor. She had no respiratory issues before hospitalization but developed some fluid in her blood while being in the hospital. She is on half a liter of oxygen and is currently in the process of tapering off it. Her pulse ox is 89 to 90 while using the oxygen. Patient states she is finally getting better and feels like she is almost fully recovered. Past medical history. Past medical history includes being type 1 diabetic, but she was not diagnosed until her early 20s. Patient has an insulin pump for her diabetes treatment. The patient had kidney failure in 1997, which led to kidney transplant. Her immunizations are up to date, and the patient has no known allergies. The patient has a history of hypertension within the past 10 years, but it is controlled by medications. The patient also states she had atrial fibrillation her whole life. The patient has been hospitalized multiple times between the kidney transplant in 1997 and her hospitalization in January 2013. The patient claims she was on her deathbed 3 times during those 15 years. Medications. The patient is on a long list of medications but does not know the doses or when she takes them. The medications include cyclosporin, Neural, and prednisone for anti-rejections for her kidney transplant, baby aspirin for her cardiac history and to reduce risk of blood clots, Lasix for hypertension, metronidazole as an anti-infective, vancomycin as an antibiotic for the infection she had developed when she entered Heartland, and half a liter of oxygen for respiratory assistance and insulin for her diabetes. Functional assessment. Patient would not state any alcohol or tobacco use in the past and present. The patient did not state any sleeping disorders and had no nutritional limitations or difficulties besides the occasional low blood sugar. Upon examination, the patient was not distressed in bed. She could move around and sit up herself without any aid. She appears thin but healthy. The patient is very alert about her surroundings and the patient care she is receiving. She is well oriented to time, place, and person. Her speech was clear and her diction was accurate while she described herself and current situation as she answered questions. Psychosocial information. Before hospitalization, the patient lived at home in a residential neighborhood with her husband. She has been married for 40 years but has no children. Her previous employment was a social worker until her 1997 kidney transplant. She was a college graduate and has a master's of social work. They have a family and friends nearby, and her sister and brother are still living. They are Catholic, but the patient did not state if they regularly attend Mass. Her husband stays with her all day at Heartland, and he is also retired. Family history. Her mother also had type 1 diabetes. The patient, along with her brother and sister, all have heart murmurs. The patient did not mention her father's medical history. Upon assessing the patient, her vital signs were stable. Blood pressure was 112 over 72. Her heart rate was 72 beats per minute. Her respiration rate was 23 breaths per minute. And her temperature was not taken because there was no thermometer in the room or on hand. I focused on 2 assessments two systems that are high priority for this patient, cardiac and respiratory. During my review of the cardiac assessment, the heart sounds I auscultated were normal, S1 and S2 in all 5 locations. Along with the S1 and S2 heart sounds I heard, there was also an abnormal S3 murmur located in the mitral valve, which explains the atrial fibrillation the patient had stated in her past medical history. Upon palpation, no bruits or heaves were found. As expected, the heart sounds were normal and the patient no longer needed her heart monitor that had been removed. The other primary assessment I performed on the patient was a respiratory assessment. When the patient was admitted to Heartland, she had extreme shortness of breath and was placed on 0.5 liters of oxygen via the nasal canal. While inspecting the patient, I found her trachea to be in line, no injuries, her chest was symmetrical, and upon inspiration and expiration, her chest rose and fell equally. Upon assessing the patient's respirations anteriorly and posteriorly, I found the lungs to be clear with no signs of wheezing or crackling, meaning that no bronchophy and egophy were present. Patient was negative for tactile phrenitis. Based on the patient's health history, 2 other assessments I would evaluate would be the peripheral, vascular, and musculoskeletal systems. Review of the peripheral vascular assessment. Reviewing the peripheral or vascular assessment due to the patient's past medical history of hypertension and the type 1 diabetes would be pertinent. When assessing the pulses of the patient, I would expect to grade them higher than normal. Also, according to the RN Journal, when patients have diabetes, they are more likely to have poor circulation due to poor insulin control. This could cause ulcers or severe skin breakdown that could cause more problems for the patient. The musculoskeletal assessment was also a priority for the patient while at Heartland since she was there to receive physical and occupational therapy and rehab. The patient had no previous problems with mobility before her hospitalization in January. She has no history of broken bones. She receives occupational and physical therapy for 45 minutes per day but wishes it lasted longer and she had more time. She received the rehabilitation care Monday through Friday but none on the weekends. When inspecting the patient, I would expect her bone structure to be at normal ranges. While performing the musculoskeletal assessment, I would expect her hand grasp to be strong and equal, her range of motion to be full and equal in her upper extremities, and score them as a 5 out of 5. I would also expect to find some weakness in her lower extremities due to her inability to walk on her own during the stay at the University of Michigan Hospital. The purpose of her rehabilitation is to get her back on her feet and allow her to carry out daily living activities on her own.